we are moving on to our next original case presentation. We have only one case presentation in this session. I would like to request Dr. Nupur Banerjee. She is Nupur Bajpayee. She is a SR in North Bengal Medical College. She will present the case. And for this session, we have our judges. Dr. Anil Sajdev says he will judge the session along with Dr. Mrityunjay Pao and Dr. Rakesh Mondal, Professor Rakesh Mondal. And Nupur, you can.
Should I start? Good morning, esteemed judges and everyone. I'm going to present my original research paper with the topic Functional Status Assessment of Patients in Pediatric Intensive Care Unit. So there have been incidences of new onset morbidity of patients after discharge from PICU, and these have been reported from countries like USA, Brazil, Argentina and Singapore. But similar data is lacking in low and middle income countries like ours. The functional status scale was developed in order to measure the acquired morbidity of pediatric patients.
Just to interrupt, the timing has been mentioned here 20 minutes. You have only 6 minutes for presentation. Another 4 minutes for discussion and the question.
So we have the functional status scale, FSS, that was developed in order to measure the acquired morbidity of pediatric patients while their admission in PICU and also on follow-up. So our study tries to assess the functional impairments which are observed in patients admitted in PICU and to diagnose any residual morbidity that these PICU survivors might hold. The primary outcome would be to assess any change in the functional status of patients during admission, at discharge and on follow-up at 3 months, 6 months and 1 year. This would be compared to the baseline scoring before admission. The secondary outcome would be impairment in functional status of patients depending on duration of PICU stay, the system that is involved primarily and the respiratory modality of treatment that we have used. So the study population was pediatric patients admitted in PICU of North Bengal Medical College and Hospital, and this study would continue for a span of 6 months. Children aged 2 months to 12 years having a PICU stay of at least more than 48 hours and a Q-SOFA score of 2 or less were included in the study, while those with congenital heart disease and malignancy were excluded. The previous study was done in Pakistan, which showed that there is an incidence of 12% of morbidity in survivors, taking that as the incidence, 95% confidence interval and 5% margin of error. The estimated size is 163. There is a dropout of 10%, so sample size is 178, which by convenience sampling is 180. We took the baseline demographic data of all patients included in study. PRISM 3 and Q-SOFA at admission were done. 40 patients have been enrolled in our study till now with a 3-month follow-up, and we continue to enroll patients in our study. So this is basically the functional status scale. A bit crowded. We need to focus on the fact that there are 6 parameters, that is the mental status, communication, motor, sensory, feeding and respiratory status. These are scored whether they are normal, and the final scoring of 5 is given if there is very severe dysfunction. So the minimal score is 6 and the maximum is 30, and as the score increases, the disability increases. The age in years mean was 3.7. There were 13 male and 27 female patients. The average or the mean duration of PICU stay was 10 days. We had 10 patients, that is 25% patients who already had chronic illness, and the Q-SOFA mean was 1.6 while PRISM 3 was 10.1. If we talk about the major systems that were involved resulting in PICU admissions, they were mainly cardiovascular in 30% cases, The second most common were respiratory and third most common was CNS with 22%, while renal cause, poisoning, envenomation, surgical and other causes formed the rest of the percentage. Now these are the scores, the mean scores that we obtained of different parameters, also the total scores. I would like to focus at the point that the maximum scoring was seen while the children were admitted in PICU, that is maximum disability was there. The parameters which were maximum affected were feeding and respiratory status, while at discharge it was slightly increased, that is 7.7, and the maximally affected parameter was motor parameter. So this shows us a trend of our functional status score. So if we compare from the baseline, during admission there was a significant increase in the functional status scoring, which is with a p-value of 0.02. At discharge it was borderline, and at 3 months it was 1, which were not significant. If we correlate the functional impairment with the duration of PICU stay, we could see that those children who had a stay of 7 days or more had more impairment in their functional status, and the difference from the baseline was also more. Similarly, those who were having CNS pathology had a higher functional impairment. Although we can see that here the baseline is also raised, that is because many of the patients with CNS pathology also had global developmental delay. And if we compare them regarding the respiratory treatment modality, those having invasive ventilation had the maximum functional impairment. So the major conclusions include that the functional status score which we saw during admission in PICU was statistically significant as compared to the baseline with a p-value of 0.02, although such significant difference was not noted at the discharge or on 3 months follow-up. The major parameters which were deranged during the admission were respiratory status and the feeding status. There was increased functional impairment of patients who had a prolonged stay of more than 7 days, and also those with CNS pathology and undergoing invasive ventilation compared to the counterparts. The residual morbidity was seen just in 2 patients, that is making 5% of the population. One patient had a CNS pathology of meningitis and showed an impairment in mental parameter, while the other was a known case of juvenile idiopathic arthritis, and after discharge showed residual morbidity in terms of feeding and motor parameter. So we have such studies done, but I did not find any such study done in Indian setup in the PICU. So Alvarez et al. Was one of the person who did it initially, and they found that there was a morbidity of around 3% in patients in PICU, and it they persisted at around 0.7%, while close neighbor of ours at Pakistan by Anwarul Haq, he had done the same scoring, and it was seen that pre-illness value was 6, while it was 6.6 in our study, and there at discharge the children had a FSS score of 7.02, while ours it was 7.7. So we continue to recruit patients for our study to have a larger sample size and confirm our findings which we have found in the subset, and the patients would also be followed up at 6 months and 1 year to assess their functional status. Thank you.
So, Dr. Nupur, this is your interim data.
Yes, sir.
Right. So, first of all, you used Q-SOFA.
Yes, sir.
So, is it validated in the pediatric ICU?
So it is not much validated no longer. PRISM-3 is considered a better prognostic marker. We use both of them. The basic was that we did not want to take very sick patients into our study because those with already poor prognosis would not survive the PICU stay. That was the only cause we took Q-SOFA and PRISM-3.
Actually, Q-SOFA and PRISM, they are not comparable. They are into different categories.
Yes, sir.
Okay. Second is, did you, whatever number of patients you have, did you exclude the CNS patients and compared, you had another, cohort of cardiac patients and the respiratory patients? Because in CNS patients, we do expect them to have functional,
yes,
problems?
So we saw the CNS patients differently, but the point is that those patients who already had functional impairment before admission, before this episode, their baseline functional status score was already increased. So we are seeing the increase from the baseline. So if they have a higher CNS score already at the baseline, we are targeting on the increased difference that we see at the admission. So that is why there was no need to exclude them.
Okay.
Dr. Nupur, how will the outcome, what will the outcome of this study impact our practice?
So the point is that whatever we are seeing is basically the functional impairment. That is, many of the patients also had motor impairment, and when they mention in their scale, they just don't mention any disease. They have mentioned us putting an IV cannula or medical devices, restrictive movement is also one of the functional impairments. So instead of patients who stay for 2 days or more, we could go for central IV cannulas. This would reduce their functional impairment because of increased poking of the IV cannulas in their limbs. So basically the study will try to reduce their functional impairment while they are admitted in the ICUs. We have also seen that patients who are being given IV fluids or parenteral treatment are considered very more dysfunctioned as compared to those who are getting NG feeds. So starting earlier feeds, keeping the days of IV parenteral nutrition or IV fluids lesser and going for the feeds first. This will also help reduce in functional impairment. So basically we'll try to make them functionally better while they are admitted in PICU. This would also help us to reduce the morbidity functionally when they are discharged.
This is related to the basic disease rather than IV cannula.
No sir, because the scaling is that, the scaling that we have got, if it is related to the basic disease, जैसे कि while the child was admitted already had limb what was not functioning or because of some other disease, but while admitted if we are making the functionally impaired, it is a better, we can go for a better modality of treatment. And yes sir, depending upon pathology, there have been effects on the functional impairment, which we have shown in the basic diagnosis and the table separately.
It's a good attempt to know something in Indian setting, but you have to validate in Indian setting also, not only the children, but in Indian setting you have to validate to apply any score, I think.
Yes sir.
Second thing, as you have already mentioned that delay is the limitation. As your number is less, so you can exclude those patients with delay or impairment, and then do statistical analysis again, so that you can know actually it helps or not, isn't it?
Yes sir.
But your number is less, I think.
Yes sir, right now we have more patients, but there are 40 patients whose follow-up was completed by June. So
No dropout.
So there have been among these 40 patients, 5 patients were dropped out. So it was 45 and we gave a final data of 40 patients. 5 to 6 patients did not
So
respond.
that has to be mentioned in your methods also, okay?
Sir. Yes sir.
Sir, any question from the audience?
So, we are ending this session. It was a nice presentation.